morning, everyone, and welcome to today's webinar presentation, Warm Referrals, a trauma and violence-informed approach to supporting clients' engagement with community services. My name is Sarah Carsley. I am an applied public health science specialist at Public Health Ontario, and I have the pleasure of co-moderating today's session. Before we begin with today's presentation, I would like to acknowledge and respect the lands, sky, and waters of Ontario, including for their contribution and sharing to support all life within. I acknowledge and respect the treaty, unceded, and traditional territories of all First Nations across these lands and waters. I would like to acknowledge that I am in Toronto, on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaties, signed with multiple Mississaugas and Chippewa bands. Please join me in acknowledgement and respect of all Indigenous peoples, their life journeys and worldviews. May their wisdom always guide our own paths forward with open hands, open hearts, and open minds for the mutual success and benefit of all in Ontario. Lastly, I would also like to acknowledge Daniel Coles, who helped author this land acknowledgement, and thank him for sharing it with us. I'll now mention a few housekeeping items. To enhance the presentation experience, participant audio visual or video has been disabled. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have any questions during the session. A discussion and question period will follow the presentation. And if at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would now like to introduce my co-moderator for today, Dr. Susan Jack. Dr. Jack is the lead for the Public Health Nursing Practice, Research, and Education Program, or PHN PrEP. Susan and her team are committed to integrating the principles of trauma and violence-informed care into professional practice and curricula as a strategy to improve client engagement and health outcomes, as well as to promote provider wellness. Welcome, Susan, over to you.
Great, thank you, Sarah. It's always such a pleasure to co-moderate with you, and really a privilege to partner with Public Health Ontario to offer this webinar series, which represents the work of the PHN PrEP team and our work in supporting public health nurses, supervisors, managers, home visiting staff, and really anyone who works with pregnant individuals and families with young children. In today's presentation, I'm really excited to welcome Dr. Karen Campbell, who's going to spend some time with us today talking about how we can best support clients, particularly those who've experienced trauma or violence, or who have experienced, traumatization or harm within different systems and services, how we can really actively support them to navigate systems and services that clinicians refer them to. And Dr. Karen Campbell is a longtime colleague of mine. Many of you will know her because I know she worked as a public health nurse for over 16 years. She's now an assistant professor at York University in the School of Nursing. And she, in her past role as a public health nurse, she worked in the Healthy Babies, Healthy Children program. She's worked with breastfeeding services. She's been involved with the Canadian Prenatal Nutrition Program. And when she was completing her doctoral research at McMaster University, she supported an evaluation of the Nurse Family Partnership program in British Columbia. And she's currently a researcher for iHeal, which is a community health nursing program for women who've experienced intimate partner violence. So welcome, Karen, and I'm really excited to turn the microphone and the lens over to you.
Thank you so much, Sue. It's always such a pleasure to come to these seminars and or webinars and to talk about the things that nurses do that are so meaningful to parents. And sometimes these things seem like run of the mill, or things that we just, after we think about them, it just seems so obvious. And I recognize that there's lots of people on this call that know this and are probably already doing this on their practice. And I also recognize that there's lots of teams that, as we've come back from COVID, that now have a lot of new staff on them as well. So I hope that you take something from today, wherever you are on your public health nursing journeys. So today we're talking about referrals, and this is certainly a big part of what we do. And I hope that today we can identify who it's appropriate to use referrals, or what I call deferrals, or a warm referral process with, and also to talk a little bit about trauma and violence informed approaches to providing these referrals, and to walk through kind of what that process would look like in a way that is supportive to clients and also helps them to engage with communities. Just as a disclaimer, this presentation is mine, and you can read the rest of this and how it's associated with Public Health Ontario. And also, as a disclosure, I don't benefit in any way from doing this work. I just feel really, really passionate about having the ability to work with PHN Prep and to support public health nurses. So I want to start by discussing trauma and violence informed care, and really we've done a few webinars now about this, but I want to make sure that we're all on the same page about what it is and maybe what it isn't. I think that this might be helpful as we come to understand why it's important and meaningful to the referral processes that we do. So trauma and violence informed care is, or TVIC, I'll probably call it TVIC just because that's what I do, but it's different than trauma-specific care or trauma-informed care. And those are, trauma-specific care refers to things like cognitive behavioral therapy or eye movement desensitization, which are treatments and specific treatments for people that are experiencing the effects of trauma by health professionals that have specialized knowledge and skills. And these are really effective for treating trauma. And I know many of you also are being trained in that. And it's also different than trauma-informed care. And that's where we seek to create safety for our clients, or often patients, that understand the effects of trauma and its link to behaviors or to health. But unlike trauma-specific care, trauma-informed care isn't about treating people's traumas, but just creating a space that doesn't potentially harm them further. There are many different models of this, and practitioners do it in different ways, but what we're talking about here is trauma and violence informed care. And what we do is kind of add the violence to recognize that trauma isn't always an individual experience, that it's not necessarily something that exists in the mind or the body of a person, but that there's more attention to the environment that they're in. So we expand to recognize that trauma is so common that we can just assume that somebody has had a traumatic experience. And now we can start to account for the intersecting impacts that systems, that society has, structural inequalities that exist in a person's life that are disadvantage them in some way. And we refer to that as violence. So racism, ableism, sexism, all of the different types, classism, all of the things that our clients come upon. So by adding that V, we emphasize that there might be historical things that are happening to groups of people that our clients are part of, or that there might be ongoing violence that is impacting their trauma. So it really shifts the focus from the person's experience of a past trauma and recognizes that we're residing within a social structure that sometimes reinforces this. And again, the V in trauma and violence informed really helps to shift the lens. So we can start to use universal precautions. And this is where we recognize that people have a history of trauma or violence, and it's not necessary for them to disclose that to us. We can assume that that is happening and treat people with respect and dignity in a way that supports them. It also helps that we create policies and practices that prevent harm by creating safer environments. And we think about even what our spaces look like whenever people come into our environments. For example, Colleen last month, and I don't know if she even shared this example while she was here, but she often talks about how certain hospitals in downtown Vancouver look exactly like what a residential school looks like. And so imagine coming into that after having that experience. And the V in TVIC also helps to not just leave the individual provider with accountability, but also think about the organizational level and what the organizational structures that are in place that support both the practitioner, but also the client. And we'll revisit this idea again at the end after we talk a little bit about warm referrals and referrals, and consider how we can support clients whenever we're making referrals to the community and to services. So now that we're on the same page about trauma and violence informed care, let's talk about referrals. So why they're important for us as home visiting nurses and family visitors, and how we can warm them up. And by referral, I mean the process of connecting someone to information or services that fall outside of your expertise or specialization. And sometimes they are within our area of expertise as nurses. And I am going to give a shout out to Michelle Shelley, a public health nurse, an amazing public health nurse in London. And she was talking about chronic health and how it's often something in Healthy Babies, Healthy Children that we refer on to somebody else, but also it falls within what we do, but maybe not something that we can completely give to a client. So where we need to provide some other specialty or some other support for clients. And first of all, as public health nurses, as family visitors, we are so well positioned to link parents with their unmet social, health, and economic needs. We provide, we know a lot about their community resources and about communities. And so in doing that, we can really facilitate and help to maintain families' connections to services. And this is a common part of our role in the work that we do in Healthy Babies, Healthy Children, in Nurse Family Partnership, or any other programs that you might be in if you're outside of Ontario. So it is a huge part of what we do. And the reason why it works is often because parents trust us. And so we're able to come into their houses to be with them during such a vulnerable time. So it works because they have that trust in us. I'm going to talk about 3 different types today, those with low, moderate, and advanced levels of support. And all types of referrals have their own purpose, and there may be times when one is more appropriate. And I think that there's a lot of skill and knowledge that goes into making that assessment about when to use these types. It requires a high degree of critical thought and understanding of your clients, their needs, and how communities work. These low-level supports, both low level and moderate, are often referred to as cold referrals. So cold referrals meaning that you're providing information to a client about another agency or service. Maybe you're checking in with a client, like, were you able to find a family doctor? You mentioned that you didn't have one yet. And also it puts the onus on the client. So it's their responsibility to contact the agency. You've provided the information, but then you leave it up to them to do it. And this is different than an advanced level support, or what I'm referring to as a warm referral. And this also has lots of different ways of being, but it's far more instrumental, it's far more active, it's facilitating the referral to actually happen. So it's looking at something like, let's fill out this financial application together for the child, for child support. And also recognizing that might be a whole visit in itself. So sometimes cold referrals can absolutely be appropriate, and I'm going to just go through a few reasons why, maybe. And if there's no language barrier, no literacy barriers, including the ability to be able to read and write, to fill out forms, to comprehend those, to have reliable access to internet or to phone, if this is how they are intended to connect with the service agency, to have other resources available to them, really basic things like food and housing and transportation and other things that they might need in order to be able to be successful in navigating these referral processes. To have other supports as well, like social systems where they can have friends that might be able to help facilitate some of this as well. There's times where cold referrals might be appropriate because there's an expectation of privacy. So maybe if somebody is going to go to Alcoholics Anonymous, it might not make sense for you to show up with them, but also your expectation of privacy too. So and I'm going to caveat this by saying I think that this is a rare thing that happens, but there may be times where you're making a mandatory referral to Child Protection Services, for example, and you're concerned about your own safety. So for sure, that absolutely is going to be important, and again, is part of trauma and violence informed care. Also, where are the resources already familiar to the individual? They've had a good experience with it. And this by no means is an exhaustive list. I'm only bringing up a few items here, and I'm sure that at your health units, your teams are able to identify many scenarios where cold referrals are not only acceptable, but they're actually perhaps more appropriate. Sometimes the timing for a warm referral isn't right, and you may assess that the client isn't ready. And so deferring the referral is perhaps a good way to move. So you're leaving pamphlets or other information because you've had that conversation, you've assessed that their priority right now isn't this referral. And in this way, you're not acting as checkbox nursing, but you're making a deferral as a part of our referral, where you're making a decision that's just as wise as any other nursing intervention that you're conducting. So not to feel like you have to just give every referral right away, make sure that they've got them just in case you don't see them again, but just to recognize that is deferring perhaps in a bad way, where you're just giving them all this information and leaving them alone. But we don't want to do that. We want to defer in a really respectful way, where we're thinking about what that client needs and not overwhelming them with lots of priorities that may not be theirs. So let's move on to warm referrals. So warm referrals involve carefully assessing the fit of the agency and how that's going to meet the client's needs to facilitate client introductions to new providers. And that facilitation can happen in lots of different ways. That might be through phoning, it might be through emails, it might just be talking to the client. It really depends on what the client is looking for. Maybe setting up joint visits if that's what's needed, and actually following up with clients to assess if the new service met their needs, how that happened for the client. Basically, what this does is move referrals from being transactional in nature to being relational. So we want to do this because studies show that there's an uptake of services, there's an uptake of appointments that are made, there's a decrease in social service needs. Parents have self-reported improvements in child health, and clients report having better experiences when they understand what to expect from community services. And this is particularly important when not all of the services that we work with may be health equity oriented or trauma and violence informed care. So really thinking about what they need and what they're going to come up against. And part of doing that requires a good bit of background information. So looking at that background work, the things that we need to do to make sure that these warm referrals are more successful. And largely this is happening at an organizational level, and maybe even preferably at the community level, where we come together to identify what services are available and resources are available for our clients. And while COVID brought way too many challenges to the work that all of you do in home visiting programs in Ontario, it also provided us with an interesting opportunity for organizations to have a pause, and I say that maybe with quotation marks because I don't know that it's a real pause, but to take a breath and kind of think about how we reconnect with our networks and our community groups and agencies about the services that are available, and how we can work together to better support our clients. At a system level, this could be a really good time to develop protocols between home visitation programs and other community services so that we can help facilitate some of this communication, referrals, and collaboration for the betterment of our clients. You may want to consider the sources that are trauma and violence informed care. And there's some good examples of these, such as advocacy services. There may be particular legal supports in your community, women's shelters that naturally do follow trauma and violence informed principles. But there may be lots of other places, and you might want to get a sense from different community organizations. What are the language? What kind of language do they use? What kinds of forums do they have? Are these gender affirming? Do they ask questions about marital status, or do they ask questions about do you have availability of supports? Just so that we can then talk to our clients about what they might come up against, so that if they do have to go into somewhere that's not going to be gender affirming, that we can present that to them, so that they know kind of what they're getting into, and help them to navigate that. If it's possible to go on a site visit, and I'm going to credit Megan, a nurse from BC who I recently worked with, and she shared with me that one of the things that she does is actually to call organizations first. So she'll call the organization and say, I have a client, this is what my client needs. What exactly is she going to go through if I refer them to you? So what information does she need to share with you? Is she actually going to be eligible? What does she need to be eligible? How long is it going to take? And what might this client get in return for this? So what is the client going to get as a result of this? So really getting a sense of the places that you're working with, those that are trauma and violence informed and those that aren't. I'd also like to discuss that warm referrals take time, and time is a commodity, and perhaps a commodity that many of us don't have. So I recognize that the value of your time. And I hope that by sharing this information in this way, that it provides some rationale and support for why as nurses we need to do this work and we need to take this time with clients. So rather than, again, leaving some pamphlets, this is part of the work that we as nurses need to do, so that we can move away from common referral processes and really download the responsibility from not just the client, but not allowing it to be so burdensome and a barrier to health, but something that we can use as a shared responsibility. And I remember many years ago, as I was nursing, and we would often talk about not working harder than the client. And I think in the 20-something years that I've been doing this, I've really come to think, like, of course we should be working harder than the client. I go out to dinner at a restaurant and the chef works much harder than I do because he's getting paid to do that, or she's getting paid to do that. They're getting paid to do that. And so why wouldn't we work harder than the client? They're in, and they have a particular need, and perhaps not at their optimal health, and in a vulnerable state, perhaps. So yeah, sure, of course we can work harder than them. This is what I've come to believe. So there's 3 different points of the referral, and I'm going to take you through this process. And this is kind of an abridged version. There's lots that goes into this, but I am trying to not talk too long. I do love to talk. So I want to start by saying that this requires a connection. So some of the work that we do so well is in establishing relationships with our clients and having that connection. I mentioned before about that trust. So starting out with a place of trust where you're establishing a connection with the client, acknowledging that they are the expert in their experience, acknowledging and respecting their identity, their unique needs, including culture, concerns, priorities, and looking at levels of risk, particularly around issues of intimate partner violence or other violence that you're at an interpersonal level that your clients may be experiencing. And then to review options with them. And as you're reviewing options, you might want to think about things like what's most helpful. How did they like their needs to be addressed? What works best for them? What has helped in the past and what hasn't helped in the past? Again, to validate their experiences, particularly where things haven't gone well in the past, that we know that there is gendered healthcare that happens, that there is gaslighting that happens for lots of experiences that women have. So, so coming to understand the reactions that they have to services, because this might give us some ideas about what they might need in their future and what referrals might be potentially the most helpful for them. It's also important to discuss with them wait lists, especially in a post-COVID era when we know that there's been shifts in the way that organizations are working and that some organizations may or may not be working again, and that wait lists are a reality in the system that we're working in. And then review the options, share that type of information with them, really allowing the client to guide their journey. Then discussing confidentiality and determining preferences for how and who should make that referral. So this is really important. So discussing confidentiality and consent, obtaining informed consent if you're in a time where you are going to be making that call, particularly so that you can let the client know that not all of the information that you have about that client needs to be shared, but specifically what information would be helpful to be shared. Recognizing that in this process of a warm referral, that the client owns their story and that they get to share the information that they want. And this can be particularly important for, again, women that have experienced intimate partner violence or coercive control with a partner, a current or an ex-partner. Some of this information being shared could potentially be harmful. So if it isn't necessary to share in order to gain access to the service that they need, then they can control and withhold that part of their story. So guiding clients to be able to determine when they need to share, and for many clients that have had experiences where they've been dismissed in the past, they may overshare parts of their story. And so really working through with them what needs to be shared. For some people, this process of a warm referral, it might help to recognize that there are resources that are available to them, and also that systems are capable of working together to benefit our clients. So it might actually, this part of being part of a warm referral may actually be really affirmative to many of our clients. And thinking again about your consent, if this is something that they want you to do, to be the person that makes that call, be as transparent as you possibly can be, talking about how you're going to make the call, if you're making the call, if they're making the call, if you want to do it together, if it can be something that's done on speakerphone, for example. So just thinking about those types of things and then following the client's request as you move through that. I also think it's really important and perhaps a strength of ours that we start with strengths of the family and the client. This is important in many different scenarios. And again, I think about mandatory reporting and again, one of the nurses that I was recently working with in London was also talking about allowing, letting clients really be part of hearing what their strengths are and hearing that you believe those things and that you're sharing that with somebody else. So as we work with agencies, and again, I'm going to think about mandatory reporting to child protection services, this can be a really positive experience. And also starting with the strengths of the agency as well. So it may be that the agency has strengths, and child services or child protection services can be helpful at skipping past wait times, and they have lots of resources. So they might be able to get funding for daycare. They might be able to get services for clients in a way that we really can't, to kind of expedient that. And sometimes if clients understand the benefit of being linked with some of these services, they may actually engage better with them and have an overall better experience with those clients, with those systems. Also thinking about how they might respond, and after the appointment, I'm going to say this, after the appointment is made, acknowledge the work that the client has done in supporting their own health and minimizing their harm, perhaps enhancing their well-being for them and for their children as well. Thinking about some of the logistics, it might be helpful if you actually take time to set reminders in their phones, to ask them if they would like you to give them a text the day before, to go over some of those logistics. It may be helpful if you have the opportunity to bring up pictures of the agency, if they're going into a particular agency, or if they're working with a practitioner, if there's a website or a photo of any of these things, to be able to show the clients what kind of place they're going to, or who the people that they're working with might be, just so that they've got that visual that they can work through. You might even want to role play. So role play with your client. These are some of the things that they might ask you. So these are some of the things that might be difficult for you. And I know that you've mentioned that you get angry whenever people talk about this. What are some of the things that you can do to calm yourself? Can we talk about some breathing exercises, some grounding exercises that we can go over? Perhaps I'm going to give you this gem and this stone, and you can rub this stone for comfort as you go through this. So just thinking about how you can support your client while they're in that. It might be possible for you to attend with the client, and if that's something that they want to do and something that you have the capacity to do, then that can absolutely be a helpful part of a warm referral. It also helps us to build relationships with other practitioners and caregivers. And again, to recognize that not all of our services are going to be trauma and violence informed. And so really thinking about what strategies our clients might need in order to support their own well-being after they've encountered these services. And then follow-up. I think follow-up is just as important as any other part of this service, as any part of this process. And thinking about what clients need, what was helpful, talking about what wasn't helpful, and making a clear plan for what are the next steps. So exploring some of the individual, the agency, the system barriers that were there, recognizing that if they don't meet, and if they don't or they didn't make a connection, that some of this avoidance behavior could be part of a traumatic stress response. So we recognize that avoidance of people, places, or activities that are reminders of trauma is a common sign of traumatic stress. So coming to seek an understanding and explore why they were ambivalent, or why they did or didn't engage, with a way that doesn't put on judgment, as to not create any divide with you and your role with the client. If there's ongoing need for communication between the public health nurse and the new support, it might actually be a good opportunity to think about at an organizational level. Do you need policies or any kinds of procedures for you to be able to better understand and work with that service, and also to discuss some of this with your team so that you all have a better understanding of what that agency experience was like, and you can share that with future clients. This is different. And I just want to put this little note in here about warm transfers. So warm transfers are a tiny bit different. And this is when we're creating, and you're probably often doing this, when we're transferring our own clients within our own organizations. And this is the idea of a joint visit. It introduces clients to their new provider and helps us to make that transfer of care a little bit more seamlessly. This might be something that you're doing if a nurse is going on a leave or leaving the program and somebody new is coming in, or if you're introducing a family home visitor. And just as I come to end, I wanted to revisit why trauma and violence informed approaches to referrals really matter. And I mentioned before that one of the reasons why these work is because clients trust us. And if you can think about this as a transfer of trust, so we're coming in a place where we can help for all individuals, but particularly for those that have either complex needs or those that have experienced past negative judgment, stigmatization, or harmful interactions, which I'm referring to as systematic disadvantage or system disadvantage. That warm referrals are really a strategy to prioritize their emotional safety, and I'm going to add to that even their physical safety, because we know that there's somatic symptoms when people experience stress and anxiety. So we're prioritizing their emotional, their physical self when we do this. We don't always know who's experiencing trauma and violence at an interpersonal or at a structural level. And so when we apply these principles of trauma and violence informed care universally, we ensure that we're meeting the needs of all the people, not just those that aren't ready to disclose their traumas to us, but those that have experienced trauma. We're not always going to be successful at preparing clients, and that's okay. But one of the reasons why a warm transfer works is because they trust us. So let's make that transfer of trust. And where systems work, and when they don't, at least we know that we did what we could to minimize any additional barrier. And one of the things that we know is that this also helps to address clients' feelings of anxiety, apprehension, or fear. It minimizes the risk that they become overwhelmed by complex systems or demands, and that it minimizes the potential for traumatic stress by being aware of and helping to navigate potential triggers. And the other thing about TVIC that I mentioned at the beginning is that it provides not just individual provider level accountability, but it also looks at how the organization can be part of creating and maintaining a trauma and violence informed environment. And hopefully, knowing this information, we see that there's organizational support of allocating time and resources to public health nurses, because this is critical to facilitating your capacity to provide warm referrals to families, and particularly families who require additional support to confidently and safely access services. I'm going to end with this quote, which is a really old quote now. If I can say that 1993 is really old, I think I can. But it says that the visitor intent on providing a holistic and family-focused service often uncovers family needs beyond these related narrowly to parenting practices or whatever the single primary focus of the program might be. And again, I think that this is the skill, the incredible expertise that comes from home visiting nurses, is that we really do have such a wonderful way of knowing what is available to our clients in the community, and being able to provide linkages to community services so that clients' needs can get met well beyond the work that we're doing. And if I can leave you with 3 takeaway messages, I would say that warm referrals are naturally trauma and violence informed care. They support health equity, and particularly for clients that are experiencing structural disadvantage. Warm referrals require establishing and building relationships, establishing trust, building relationships with our clients, and that organizational and system changes are absolutely necessary so that nurses have time to do the work that we need to do. We also have some of this information on our website. So there is this resource that's available for you to download and share with staff that are onboarding or staff that maybe couldn't be here. So some of this information does exist on our website, and you can reach us however, anywhere that we are. We're on social media, we have our website, so please feel free to reach us as you need to, and we're always happy to discuss and work with public health nurses about these important practice topics. And I'm going to throw it back to you, Sue.
Great. Thank you, Karen. So appreciate right at the beginning, you sort of said, making referrals is part of nursing and clinician practice, and sometimes it's run of the mill, but it's really not. And you've really given us a sense of how to do this work. And while you were talking, I was just really reflecting, and this is going to be maybe a little bit of a comment for supervisors or managers, or if we have any directors here, anyone who is responsible for how nursing or family home visitor or clinician time is used or recognized within an organization. This process of warm referrals is upfront work, and this is important upfront work to engage in, because if we do this work up front, maybe we can really put some strategies in place to really support clients to feel safe and to follow through and to engage with what are very complex systems. And I always think about what's our why? Why do we do this work? And our why, I think, well, I know my why is, how can I engage as a nurse to improve the health and social outcomes for pregnant individuals and families with young children? So that's my why. So there's value to doing this upfront work to support them, into accessing those services that can hopefully improve their health and social outcomes. But the thing that I want to share that I've been reflecting on for supervisors and managers and directors, or anyone here who has power to influence how workforces engage, is that this work takes time. And so, when I think about nurses doing home visits, some organizations maybe count how many home visits can you do in a day. But a home visit is not just that time spent in the home or the time spent traveling to a home. This work of doing warm referrals takes time. And how, to do TVIC, organizations have to rethink about time allocation to staff. We can't do this work, and we can't do this work well unless our organizations that we work in value the time that it takes to engage in a process of navigating warm referrals. So I think that's just, I don't know, that was one of my reflections, Karen, as you're speaking, is how do we support organizations to ensure that they recognize that this is important nursing work, clinician work, family home visitor work, and it needs to be given the time and space during the day. So anyways, that's my reflection. And now I see questions coming in.
I love your reflection. Really, I fully agree. And I think we are living in a place where we want to be anti-racist and decolonizing and all of these important health equity approaches to care. And trauma and violence informed care is really a big part of doing that work.
Yeah. And I often, when I'm working with senior leaders, and when we're looking at, costs of different programs or what's the evidence, all of this upfront sounds like, well, this is a lot more work. This will take a lot more time. And do we have that? And when you need more time, then, do you need more nurses in your organization to do more work, or how does it influence caseloads? But I always like to argue, and I know we have a big public health audience here, so I don't have to do a sell on the value of upstream work and prevention, but I would much rather invest my time as a nurse in doing this upfront work now than the opposite, the inevitable of experiencing frustrations that a client didn't follow through, and then I have to get them on another wait list or make another referral, right? So we do this work, but it's either do we do it up front and support them to really make a strong first connection up front, Or do we wait later when all of a sudden maybe we're experiencing frustrations or worry because they've missed an appointment, they've canceled an appointment, they're back on a wait list, or the client didn't follow through, which is not, that's stigmatizing language. And, I never put the responsibility on the client. It's that our systems are complex. So I always just think, let's do this work up front. Then if we don't do it well now, it creates problems later on for the client. Anyways, I'm going to get to some questions. So one question here, and Karen, with your experience in HBHC, I'm hoping you can answer. If not, it might be one we have to take back to some supervisors. But the question is that cold referrals seem to align with the definition of suggestions or recommendations in ISCUS and the HBHC guidance document. Would you agree that these are synonymous, that we make what you defined as cold referrals aligns with that definition of what are suggestions or recommendations in ISCUS?
I absolutely, as I was making this presentation, it was one of the things, and now I haven't been in ISCUS for long. I have no ISCUS feelings anymore. And anybody that's in ISCUS might know what I mean by that. But yeah, I don't have any stress. I don't have anything, but I remember that, and I absolutely thought that. Like, as I was going through, I thought it even reminds me of kind of like just that checkbox nursing that we don't just see in public health. It's in lots of different places. But yeah, like, these are just recommendations that I'm making, and here you go. Like, here's all the things that I need to refer to you, like that I need to recommend to you, or here's all the. Anytime that there's a checkbox, I get a little bit anxious, because then am I nursing because I'm filling this out, or am I nursing because I'm doing the right thing? So yes, absolutely. I had that same thought, and maybe this would be better suited going back to some of the managers and that are currently doing that work, because again, I haven't done it for a really long time, but yeah, that definitely came into my mind as well.
Great, so that there is some synonymity.
Mm-hmm.
That just leads to the next question, which is just a question. Again, if you could just refresh, or just please share again, what is a cold referral, right? Just a brief synopsis.
Yeah, so cold referrals, in how I was taking them up, are really that we're giving information. We are perhaps doing a check-in, like, did this happen? Did you talk to your doctor? Did you find a doctor, even more so? But we're giving information to somebody. You should find a doctor, like that kind of information, rather than actually taking the time and going through and maybe working out with them, like, here's a list of doctors, let's take this appointment and call some of them and see if we can get you in. Or I know that there is this one nurse practitioner in town that is taking clients. I'm actually going to call, because I know that this client needs somebody. So I'm going to make that call and see if I can use mine. Is a warm referral. Cold referrals are just leaving the information. Essentially, in a nutshell, I would say that cold referrals put the onus and the work on the client. Warm referrals transfer some of that responsibility, so that it's a shared responsibility between the nurse or the home visitor and the client.
Great, thanks, Karen. And just, as we were chatting and seeing a few of the questions in, recognizing that we have a large Ontario public health audience here, but we also have people attending from across the globe. I see people from the US, from Thailand, that have joined. So it just to clarify that ISCUS, sorry for using the acronym, and I actually don't even remember what the acronym stands for, but it is the data system that's used in Ontario that captures home visiting data for the provincial Healthy Babies, Healthy Children program, which is a home visitation program that is implemented and delivered across all 34 of our health units. So I thought I would just throw that in. Okay, I'm just looking through the questions here. Okay. Yeah. Okay, this is, boy, something okay, there are many areas or regions where there are no or few services available, also huge wait lists. This is a challenge for clients and public health nurses. Any thoughts, Karen? Reflections?
Absolutely. And so I'm also going to say again that time is a commodity and time is important. But I also think that particularly in my interest in rural health as well. So where there's organizations where there's not a lot of resources that are available, there aren't services, the same amount of services, or that there's long wait lists, I really think that it's important that we're facilitating nurses to work to their scope, so that we're practicing to the full scope. So I used the example of Michelle, who talked about working with chronic pain, and absolutely, like, this is within our scope and our understanding. So maybe you don't have a chronic pain clinic or practitioner in your community, but there are some things that we can do that are within our scope. So if that's something that your program is able to do, and I think that it's beneficial where we can to support nurses to work to their scope. And then I think that the other thing that's important is that, again, we're looking at an organizational level. So that's at an individual level. When we're looking at an organizational level, how can these systems work better? And particularly, COVID taught us a lot about the ability to use platforms like this and how telehealth could support clients. So are there opportunities for support to be delivered in different ways, and what infrastructure needs to be put in place so that that can happen? So at an individual level, I think that nurses can be supported to work to our scope of practice, and at an organizational level to better work with services so that we can work with services outside of our communities.
Great, thanks, Karen. And as questions are coming in, I'm seeing some comments that are really endorsing and reflecting, this important work that is done by nurses in very complex systems. You just acknowledged, right, in communities where there's not few resources. And I just want to share a few of the comments that are coming in. Because sometimes I always think if we make the, invisible visible, we don't feel as isolated or alone when we go, okay, there's other people that are feeling the same way across the province. So someone has commented, we're under incredible pressure to produce numbers, number of visits, number of NCAS scales, number of PIPE interventions completed. Often health units or management are only looking at direct service of what gets counted in databases, and not the complex case management involved with our families. And someone else commented as well, we feel the pressure to fulfill the quantifiable, reportable data. But what we're talking about, is this qualitative work. This is nursing practice. And it sometimes feels like it's not recognized in the way I wish it would or could be. How do we get managers, directors, medical officers of health on board? And I don't have answers. And I think these are really important questions, as many individuals in Ontario, across the province, across the globe are re-envisioning in this post-pandemic period what home visiting programs and what supports for families can look like. And I think as a nursing community, and I'll speak to the nursing community here, I know we have many other people who have joined us, but to our nursing community, is that for a long time, a lot of the work of public health nurses in home visiting has been invisible. No one has ever counted all the hours it takes you to locate and find a missing client. And if you're a public health nurse, you know what I mean by those missing clients. They've just disappeared, and the time it takes, really to reconnect, refine them. No one counts that. But this is essential nursing work, and it is part of complex case management. And so I think as a collective, and it'll be something I can take back to our PHN prep leadership team and a collective to others of you who are in positions of power and influence or have connections with chief nursing officers. How do we begin to have these conversations to have this nursing work valued, acknowledged, and to have it counted? Because this type of qualitative work, if we say, or what I think is expert nursing practice, is the type of work that needs to be done if we want to enroll clients in program, to maintain and retain clients in program, which are ultimately strategies to, again, supporting clients to meet their goals and improve their health outcomes. So thank you for sharing those reflections.
Can I just add one thing to that? Because it's making me think about, again, clients trust us. And if we give referrals or cold referrals where we're just giving information and we send them to places where they're not being supported, where they're being further harmed because we're sending them into systems that are broken, and we know that. So if we're sending them into places that are reinforcing stigma or negative, harmful effects of all of the different discrimination that they may experience, and we haven't warned them, we've also broken that trust. And so, and I recently wrote a poem using nurses' words, and one of the things was about they have no use for us once the trust is gone. And that quote from one of the nurses just really resonates with me, because we have to make sure that we are continuing that, or the clients won't work with us. And if they're not working with us, we're not meeting our goals anyway. So I really appreciate that ability to switch out of quantitative, because what does 20%, why is that necessary? If we're doing cold referrals, if we do 100 cold referrals and they're not taken up anyway, what was the reason for them?
Okay, and Karen, we're going to have time for one last question before I do a last close up.
Okay.
So, well, one question is, can warm referrals be done in community settings? I'll answer that. Yes, absolutely. And then Karen, this last question I think is so important, and it's building on what you just spoke about. It says negative experiences with an agency during warm referral processes influence my or the person's readiness to refer other clients. How might we address this issue?
Yeah, and I think, again, both on a individual level and on a systems level. So again, thinking about trauma and violence informed care, it needs to happen not just at your level. So at your level, yes, you're going to do those things where you're going to say, listen, this is what happened. This is what happened to my clients in the past. This could happen. I know that they're not gender affirming, and I know that that's something that's important to you. So that you're giving them an upfront warning of what they're going into, which is why it's important for us to be making those calls and not necessarily like even downloading. I was trying to think of what we as nurses could download to maybe clerical staff. Can you get this list of community services together? But we need to do that work so that we can understand and we can make those assessments about how the types of language and the types of forms and how these agencies are interacting, so that we have that information and that knowledge to share with our teams. But yeah, so that needs to happen at an individual level, that you really give them the best chance going into it, that you work with them about, when you feel angry, what are you going to do? And do that role playing with them. Those things you can do at an individual level. At an organizational level, absolutely. We need to work on a community basis about how we can further have this idea of trauma and violence informed, and trauma and violence, like reducing that stigma and discrimination that happens in all sorts of systems and sectors, reducing that at a community level. And it is part of my not so secret plan for world domination, having trauma and violence informed care across society.
Great. Thank you, Karen. And then I also think, when we know that there's other organizations where maybe the experiences haven't been as great for clients, that within public health leaders sit at many tables and have responsibilities for looking at service coordination and pathways. And so I think we have a responsibility when we're working from a TVIC approach, is that, yes, we focus on these interpersonal interactions, but then as public health leaders, when we sit at broader tables with other agencies, how do we have those conversations and share these ideas of TVIC? So anyways, thank you. Oh my gosh, there's always so much to talk about, but I want to thank everyone today for coming. Thank you to Karen for presenting, for Sarah for co-moderating, and thank you to everyone who has joined us for the Public Health Ontario PHN Prep webinar today. And before you all log off, there will be an evaluation that's coming. Please fill out this anonymous survey. And we don't have any speakers for the fall. Our next series starts September 20th at 9:30. On the survey, tell us who are speakers that you want, what are topics that you would like to hear. And our focus is always on the practical. How can PHN Prep provide some professional development around how to do this work? We want to get always to the practical. So on that evaluation, please tell us the topics that you want us to focus on. If you know of any great speakers that you want to hear from, we have some resources to support bringing speakers in. So please give us that information. And you can access our past presentations and view confirmed upcoming sessions both on the PHO website as well as PHN Prep. And thank you to all of you, and really have a wonderful day. Take care. Bye-bye.